Okay, we are going to get started, and I am incredibly excited that we're here today. And I super appreciate all of you guys for joining us and honestly taking the time. For those of you that don't know me, I am Erin McKenzie. I'm the VP of Solution Engineering here at Medical Solutions Group. And today's conversation is really going to be kind of grounded in data, but it's also ultimately about decision making and how healthcare leaders are kind of evaluating labor cost, speed, and sustainability in the market that we're in right now. So before we jump in, I would love to introduce the voices that you guys are going to be hearing from. So I am joined by two people who bring very different but very complementary perspectives to this conversation. I've got Adam McDonald, who is managing director at KPMG and led the research and analysis behind the 2025 US Nursing, Allied Health, and Therapy Labor Cost Study. Adam, if you don't know, for those of you that don't know, Adam works really closely with healthcare executives on workforce economics, strategy, and honestly, kind of operational performance. And I'm also joined by Holly Bass. Holly is the executive director of NATHO and brings deep industry and provider perspective with a focus on transparency, ethical practices, and the real world realities that facilities are honestly kind of navigating every day right now. And I'm truly grateful for you both for being here. So thank you guys.
Thank you for having us.
Yeah. So before we kind of jump in, Holly, I would love for you to share a bit about NATHO and like the driver behind commissioning this report and why honestly kind of now felt like the right time to kind of revisit the labor cost study, as I know that the last one was conducted back in 2017.
Yeah. Well, NATHO stands for the National Association of Travel Healthcare Organizations, and essentially we're the trade organization. We work with all the vendors, suppliers, and healthcare staffing companies that serve our industry and our space. So that's what we do. And we provide resources, education, webinars. We have committees in place, roundtables, and we provide a lot of industry data, surveys, benchmarking reports, and we have an annual conference, and amongst other things, really to serve our membership and their needs. But you also asked me, thank you for asking about NATHO and what we do, but you also asked about the driver of the study. And I think, as you mentioned, our last study we commissioned back in 2017, and that was almost 10 years ago already. And prior to that, we commissioned the same study back in 2011. So you will find that the findings and the results are very similar this year to what they were back in 2011 and 2017. But we did have this one little thing happen between 2017 and 2026. And that little thing was called COVID, right? And so during COVID, this study would have been and would have shown different results, right? Mainly driven because of the dynamics of the supply and the demand that really hit our industry hard during those COVID years. We were faced during that time with extremely urgent and highly critical care needs nationwide. Record high volume orders. I've been in this industry for 25 years and never seen the amount of open orders that we saw during COVID, again, nationwide. And we all know also that there's a shortage of clinicians, particularly nurses. And that shortage of labor was really just exacerbated by COVID. And then the last thing I'll mention here is that our clinicians that were out in the field during COVID, they were demanding and yielding much higher pay. Travelers were faced with more difficult circumstances around traveling and riskier assignments to leave home and go out and provide patient care. And so all of that dynamic of supply and demand particularly hit the bill rates hard, right? And climbed, those bill rates climbed. And so what happened is all of that supply and demand and the increase in bill rates caused what I would call tension between the healthcare staffing companies and then the facilities and hospitals. So now here we are in 2026, and we think things have quote unquote normalized. And we thought it was important time to do a refresh of the study, but also get our industry set on some fresh footing. I always like to remind everybody about the study is we did commission the study, but we always use a neutral source, which is Adam and his team, because we think that adds validity to the results. And then the data, the information, the categories, and a lot of the different topics we're going to talk about, they actually came directly from hospital executives, nursing leaders, financial leaders at the facility level. So it's an undertaking every year when we do it, but I think it's very valuable and kind of the data and the readout that we get from it.
I couldn't agree more. And thank you for setting the stage here, because I think that's so important for everyone to kind of understand. And Adam, before we kind of move into the findings, do you kind of mind kind of briefly sharing how KPMG approached the research and kind of what gave you that confidence in the data behind the report?
Yeah, absolutely. Consistent with, the 2011, 2017, and now the 2020, 5 reports. It's survey based, so we focus on speaking with a wide range of senior executives that are all at the, health system or hospital or provider level, and we kind of aim for a span. So we make sure that we're talking with organizations that have a range of bed sizes. We talk with a range of different titles, lots of nurse managers, HR directors, CEOs, COOs, CFOs, CNOs, CMOs, all those sorts of different titles. We look for a mix of facility location, both from a regional perspective, as well as speaking with folks that are in more urban, rural, or suburban geographies. And then there's a few things that we specifically looked for a little differently in this study. And namely wanting to expand in not just being in the acute care setting, but also talking with folks that have experience in some of those ancillary care settings and specialty hospital settings. Because as we get into this report, one of the other things that's really, changed in the last, 5 or 6, 7, 8 years since the last report is the focus not just on traditional kind of, nursing staffing, but also having, travel staffing, supporting other roles in allied health and in therapy as well.
I so appreciate that context, and I think it's so helpful for setting the stage here. And I'm going to share a single line from the study, and I'm going to kind of pause here for a moment for people to read this. But basically, when all costs are considered, traveling staff is less expensive than their perm counterparts for nurses, allied health, and therapy roles. And I know this kind of challenges some long held assumptions, but I know that it's also consistent with what we saw back in 2017 and 2011, but it also oftentimes kind of ends up being misunderstood. And what I feel like why I wanted to share this is what it doesn't say is just as important, because this isn't suggesting that travel replaces perm staff. And it's also saying it's not just about hourly rates. But what I think that it does kind of highlight is that when you look at total labor cost, including the attrition, the onboarding, the non-productive time, and kind of even structural expenses, those economics shift. Adam, I have a question for you. Why was it important to kind of frame these findings around fully loaded or baked in costs rather than just kind of simply comparing to the hourly rates?
Yeah, no, I think it's a great question. And I know we'll talk about this a little in detail as we get into some of the numbers of what all the cost categories are. But maybe in general, without getting too into the weeds, we recognize that a lot of times costs are determined by looking at what is sitting in a specific line item of an hourly bill rate for a travel nursing or an hourly wage. But even within kind of that hourly wage, we know there's baked in fringe and benefits in there. We know there's insurance costs in there. But then there's this long tail too of, as we think about the life cycle of people management, there's training time that needs to take place. There's time to recruit that's going to sit in a different budget entirely. There's going to be, potentially non-productive costs that are baked into some of that training time, some of that onboarding time, before they're kind of fully ramped up and able to be staffed. And so really the impetus of this study and looking and trying to break out all these different things is to try and put really in one place, for maybe the first time ever for a lot of folks, the true costs on a page and everything rolled up, recognizing that within an organization, those costs are heading to different departments, heading to different kind of areas of the organization. And so they're not always seen in one place.
I think that's so helpful. And I think that really just helps frame the conversation. So what we're going to do is we're going to jump in, and I'll be quick here, but we're going to look at opening up a operating environment that healthcare leaders that are listening right now are kind of experiencing and navigating today. From there, we're going to definitely walk through some of those insights from the study and really kind of identify what does this data mean for our workforce strategy moving forward. So I'm going to kind of dive into what are we navigating? And Adam, in the study, I appreciate that you opened up by kind of acknowledging the reality that healthcare leaders are experiencing. Like, we are really finding that cost and speed are no longer separate. They're honestly happening more like simultaneously together. And I know we saw that in our data as well. In our recent Medical Solutions Client Workforce Insight Survey, we identified delays in hiring, turnover, and late starts, all kind of being some of those biggest friction points. And I mean, we even had like 60% of leaders were citing the clinician shortages, as you guys can see in here. And then, I mean, on top of that, you add burnout, you add retention pressures, and like every staffing kind of decision right now, I think becomes a lot more urgent and a lot more complex. So Adam, I'm gonna ask you another question, but like based on your kind of work with health systems, why have like these cost pressures and speed become so tightly linked in like workforce strategy? And how do you see facilities or organizations like experiencing that tension operationally, particularly in that like high acuity or hard to staff areas?
Yeah, absolutely. Well, I think in general, as there starts to be shortages on the staffing side and there starts to be burnout, all these things, what we get really close to is it becoming a barrier to care delivery in the first place, right? And then in the broader picture for a lot of these health systems, they already are dealing with reimbursement headwinds. The cost pressures are not just on the labor side, but certainly on the non-labor side as well, with exploding IT budgets, and challenging drug prices and other costs that are supporting there. And so labor kind of fits into this broader picture of, a challenging margin environment for many of these health systems. But the most important kind of piece for labor specifically, of course, is that it is that gating item. It is a barrier to care delivery and patient care. And so where we see the biggest alignment of those, hard to staff areas, and where we see the biggest pressure on we need a workforce strategy or we need workforce solutions here, is in the areas where there is no substitute. It's non-elective. It's not a situation where we can kind of sort out a plan down the road. It has to, maintain the current level of care, current level of utilization and capacity management in order to make sure that the organization can keep providing the high quality care that they've promised to their communities.
I mean, that totally makes sense. And I think, I mean, everything that you've just kind of stated, it kind of even shows like that tension that's happening out there is kind of what really led to the study overall. So I super appreciate those points. And I mean, what I want to also do here is on this next slide is I kind of want us to look beyond those hourly rates and how honestly perm costs are structured today. I know payroll is roughly 60% of total cost, as you guys can see here on this slide, where those 40% is the fringe benefits, the onboarding, the training, the attrition. And oftentimes I think that we see those evaluated very separately. And the key point is that much of that cost does not flex with demand. I think that's really critical to call out. And even as like volume changes, those structural costs remain. I mean, Holly, more so for you, when facilities begin evaluating total cost more holistically, what shifts in that conversation?
Well, I think what comes to mind to me is historically our industry has looked at two numbers, bill rate and then the average pay of a permanent employee. And I think what not just shifts, but changes the conversation is that when you take into account all those fully loaded costs that weren't being considered or thought of before, we realize that's really not an apples to apples number, right? So I think what it does is it opens up an opportunity for, I think, the staffing companies and the facilities to work together and partner differently. I think over time, the healthcare staffing companies or travelers, for example, they were putting them in a category of like, this is an expensive solution or this is an alternative if we need it. And then in a lot of cases, it was like the last resort, we'll go to travelers if we can't fill these ourselves. And I think now it just kind of shifts the conversation a bit to actually travelers are a competitive solution, I think, to really address all their staffing level needs. So.
No, I couldn't agree more with you. I think like when those like structural components are also like brought into that same analysis, I mean, the comparison between permanent and labor then looks different. So you can kind of really see that full picture. And I mean, to dive in a bit more here, this is kind of that moment when I think assumptions get challenged as well, because when fully loaded costs are included, your wage, your benefits, your onboarding, et cetera, those comparisons shift. And I think the takeaway isn't that like one model replaces the other. It's that when you, and to your point, Holly, it's like when you look at the total cost, not just the rates, those economics can change. And I know this isn't new for us because your 2017 study showed a 7% differential in total cost. And like with travel being more cost effective versus today, where we continue to kind of see travel still showing up as a more affordable option. Adam, like when looking at the fully loaded comparison, what all is included that results in travel coming out as like the lower total cost?
Yeah, absolutely. I think this is the number one question for anyone reading this study is what's behind all these numbers, right? So on the permanent side, as you mentioned, 60% of that represents the base wage that we expect to see, and that's the number that everyone's familiar with. On top of that, there's other payroll costs. This includes PTO, holiday pay, your overnight premium or differentials, anything you pay for internal float pool, maybe parental leave. It's got your other typical benefits and insurance like health, vision, dental, disability, life insurance, all those typical things we know about. There's also some risk management costs, so medical malpractice, workers' comp, those sorts of things. And then we kind of switch more to the marketing side of the house where we have recruiting costs. So for a portion of kind of marketing and advertising, we also see a good contingent of bonuses coming in, sign-on bonuses, education reimbursement bonuses, retention bonuses, those sorts of things. And then we have kind of a bucket of training or non-productive costs. And this really represents the number of hours that, a permanent hire needs to spend either in training or getting kind of onboarded and up to speed on everything for the organization before they can start, full shifts, for the hiring organization. So this is, orientation, it's onboarding, it's systems and process training, it's any continued education that's needed up front as well as in the later years too. So that's kind of all the buckets. And just to give a sense of how, this survey is conducted, essentially we work with these healthcare execs that we're speaking with to kind of list out all of these costs and get ideas from them on each bucket, how much time, how many dollars, those sorts of things, so that we can come up with this estimate that gets tacked on ultimately to those base wages at a position by position basis to take a look at these comparisons.
I so appreciate that. And that's what we're going to kind of get into in this next slide is like the non-productive time, the volatility, the attrition. And I mean, I think when you look at the full cost structure is super visible, then the conversation also shifts from that travel is expensive to like, what are we actually measuring? And I think that's so helpful here. And to your point, you were referencing a couple of different key data points, because when we look at why those total cost shifts, it's not about wages. It ends up being about the structural like cost drivers. And I mean, you mentioned this as well, but I mean, first we see attrition, which was about, I believe we saw about 12% annually. And this is each departure is going to drive like recruiting costs, that onboarding, your vacancy coverage. I mean, the second that we saw was the non-productive time, which was roughly like 10%. That goes to the orientation, as you reference, the education. I mean, you name it, it's kind of a part of it. And then that third is the onboarding. And I know the study kind of pulled this out, is that oftentimes, like many people are spending over 150 hours on onboarding, which impacts the ramp up time and productivity. Holly, when facilities look at all three of these together, are they evaluating them as like structural cost drivers, or are they still largely viewed as kind of separate operational issues?
That's a really good question, because it probably depends on how connected the hiring managers are to the financial leaders of the organization. So I know, and that the C-suite completely understands structural costs, but I'm not sure that hiring managers are financially trained, right? Or financially educated around some of these costs and how they tie back. So I don't know, like if a nurse manager that's, working on her day-to-day hiring, or maybe a nurse manager that's, working on ramping up for flu season. I don't know, but I would have to say yes, there is still probably some disconnect between the structural costs and operational issues, because I think that this study does kind of illuminate that gap.
I think that's so helpful, because I think also like when we do evaluate them together, like the total cost becomes a lot more clearer. That picture, you can kind of see everything all together. And I know that for us, like cost is only kind of one part of the equation. I think that we also need to look at time, because time is just as financially material. And I wanted to kind of pull this slide out. This was some details that were from the actual study, where speed is no longer convenience. It is a risk mitigation. So like time to fill now carries like real financial and operational impact. And travel roles are typically filled, as we can see here, in 2 to 3 weeks, while like perm hiring can take months to reach productivity. And I think that difference really matters and is important, because when like roles stay open, cost shifts to overtime, burnout, delayed care. I mean, we also are seeing, I mean, for the leaders that are on this conversation, I mean, you guys are probably also seeing like margin pressure as well. And I think when we look at that cost and the time together, the conversation does shift. It's no longer perm versus travel. It becomes, how do we actually design a workforce strategy that kind of balances the demand and stability? And I think that really kind of leads to that workforce design, which I wanted to kind of show, because the goal is not choosing between perm and flex labor. It's about designing how do those work together, is what I'm kind of taking out of this as well. I think core workforce plus flexible workforce equals intentional workforce balance, which is so key. And I know the data doesn't suggest replacement. It just suggests a redesign or a design. And in this, you can see my top 2 bullets of each, where stability and agility, they're not opposites. They basically are complementary to one another. And in many systems, that includes that 5 to 7% flexible labor is built in as planned capacity. And the reason why I'm bringing up is I think this distinction really matters, because I think when flexibility is reactive, it feels expensive. But when it's designed, it becomes capacity management, which is super important. Adam, from an economic and planning standpoint, how should leaders think about flexible labor as part of their kind of deliberately designed workforce, rather than really just a reactive expense?
Yeah, well, I think, you said it perfectly right there, where it's a shift from being reactive. I think any type of reactive management, and this isn't just for labor strategy, but any type of, whether it's being reactive to patient demographics shifts, or being reactive to service offerings, or how you're going to be reimbursed, et cetera, even being reactive to new CMS requirements, right? Where you're always going to be caught on the back foot and end up spending more time and money than you hope to. And so integrating this into strategy, just like you would any type of strategic planning, just like you would taking a look at your patient life cycles and looking at how, what busy periods look like of the year, what busy periods look like at a department level. Can you start to identify short staffing in advance that might come up, where you might have more challenging retention areas and are expecting a surge? When you kind of shift it that way, and you're right, you have this pool of flexible staff that can be really redeployed in these areas, and you're being proactive about not only having the pool set up, but about understanding where they might need to be deployed. Obviously, your speed to impact becomes a lot quicker, but your overall cost becomes less too, because a lot of the costs that we are seeing on permanent staff are because of, blitzes that are happening to try and get those positions filled as quickly as possible. And there probably are opportunities for potentially reduced cost on things like marketing and recruitment, when we're not kind of in panic mode of trying to hire as quickly as possible to fill the positions. And we know that we're going to be covered by having this flexible workforce supplement.
Yeah, no, so agree. Like when that flexible labor is kind of built into the workforce design and we're using it, we're then kind of being smart about it and intentional about it, instead of using it as that emergency like lever. So it becomes planned capacity and not last minute decisions, which I think is so important. And when it is treated as like that planned capacity, I think it honestly like changes also how organizations also think about partnerships. And facilities are really no longer evaluating agencies on one factor. And the data told us this. They're really looking at evaluating like quality, cost, performance, speed, and reputation all together. And honestly, like quality like is very, and cost are super close behind that as well. And this really becomes no longer transactional. It also becomes a lot more strategic in those partnerships and who you're looking at. And also, I think that like expectations are rising. So these partnership models are beginning to evolve even more, we're seeing. I know many organizations are moving towards a more centralized approach, including like MSP models, so they can gain greater visibility and control. And I know that was in the study where 78% of facilities now actually prefer an MSP model over a less centralized model. And the reason for that is like, when these partnerships narrow, expectations increase. So like transparency is no longer optional. It is critical to the overall partnership. And that's honestly where that visibility and kind of the governance of the entire program becomes essential. It has to be there. And I know one of the other things I wanted to kind of touch on is like, what we're seeing is not just kind of like ranking shifts. I think that it's also a shift in expectations. If facilities are evaluating partners across multiple dimensions. So I know I touched on a few of them with like quality, cost, performance, speed, compliance, so transparency, like they're doing this all together. But at the same time, organizations are narrowing those partnerships and raising accountability of them as well. So they're asking for stronger reporting. So if you're listening right now, you should be asking for these as well. You want stronger reporting, you want clearer visibility, and you likely are going to want more defined governance of owning the structure. And I know that the study reflected this. I mean, 70% of facilities cited improved speed and quality as the primary reason for choosing a structured model like an MSP, with cost, transparency, and compliance was like super close behind that. And this shift is really kind of what I've been seeing, like reshaping kind of what the workforce strategy is. And when these leaders look at all of these together, I think that the decisions start to move from that reactive state that Adam and Holly, you guys both mentioned, to really a lot more intentional. And that really kind of brings me to like a bigger leadership question across the board. And I think I'm going to spend a little bit of time here because I think this is important, because this conversation we're having is not just a cost conversation. It really becomes a leadership design, and how are we a leadership decision. It's about kind of how do we design this workforce strategy in an environment that demands what I referenced: the speed, the quality, the governance, the visibility, the sustainability, all at that same time. And whether we continue reacting to workforce challenges or kind of start redesigning them. So I'm going to ask you guys both the same question. And Holly, I'm going to start with you. But if healthcare leaders were to take one mindset shift from this study as they plan for the next year, or 3 years, 5 years, what should that be?
I think I would just suggest that you look at your approach to staffing and the usage of travelers just through a slightly different lens. Travelers and contingent labor, and Erin, you mentioned this a couple of slides ago, should be a complement to your hiring process, and it should work within your hiring process. And I think if we, work together and look at everything as a partnership versus a labor strategy, and I've heard Adam say this before too, like just as a short-term labor strategy to fill a gap that's temporary, actually looking at it like a solution and a partnership and as a competitive solution, I think it just kind of changes the conversation a little bit. I think travelers and contingent labor are a competitive solution to help deliver patient care. I think it also helps drive patient care in communities and also get the labor where it's needed the most. So I just think a fresh lens and kind of a consideration to all this data and all this information is probably what I would say.
I so love that. And I so agree. Adam, I'm going to ask you the same question. Anything that you would kind of take away or kind of give someone for the next, as they're starting to plan?
Yeah, absolutely. I'm going to do my best to not be duplicative with Holly, because I agree with everything she said. But I think I'm just going to come back to strategy. As you think about planning everything with your organization, I think this is going to will always be a crucial pillar of how healthcare is delivered, and how we treat it. And so if this study teaches anything, I think it's that like most things, you kind of have to view everything holistically. So that means not hyperfixating on exactly what the hourly wage is, but understanding the kind of upstream and downstream implications of where costs flow and what the overall solution is. Because at the end of the day, what these costs are for labor is the cost to deliver care, the cost to provide, health services to healthy communities, et cetera. And so that's kind of the shift that I think needs to take place.
I think that's so spot on. Like, I appreciate both of those insights here. And I mean, really, like, the study reinforces that, like, the future of staffing isn't about choosing sides. It's really about being deliberate. And we need to look at building kind of workforce models that are going to flex with that demand across the board. And I think when leaders understand that total cost, not just hourly rates, the strategy becomes a lot more proactive instead of that reactive straight. I know we're right at time. So Holly and Adam, thank you so much for your thoughtful insights. This was so helpful. I know I learned a lot, and I'm so appreciative of you guys, and I'm appreciative of everyone on this call. I know we didn't have time for questions, so please don't hesitate to email any one of us or all three of us, and we are going to get all the the questions and answers all back to the entire participant list. And so thank you everyone for listening today. We appreciate you.